All right, here we are, chapter 24, Endocrine Emergencies. This chapter has a lot of information that really does apply to EMS, or at least we see a lot of calls that are related to this chapter. So this chapter is going to be broken up into two parts, and it will contain a lot of information. So let's go ahead and get started. Of course, it's important to understand that the endocrine system affects nearly every single part of the body. When it's off or out of whack, the symptoms of a malfunctioning endocrine system can be quite subtle. But quick recognition and treatment may be critical in some instances. So there are times that when an endocrine emergency can be life-threatening, and it can get that way really, really fast with very little warning. The endocrine system, of course, helps regulate everything in the body, and it often works hand in hand with the nervous system to keep the body in balance. Key parts of the endocrine system include the hypothalamus, the pituitary, the pineal, thyroid, parathyroid, thymus, and adrenal glands. Of course, the pancreas is a big part of that, and then the ovaries and testes play somewhat of a role, kind of mixed up in there into the whole bunch. Endocrine glands release hormones into the bloodstream. These hormones are essentially chemical messengers that travel to the target organs and tissues and tell them to do a particular thing, and all of this is with the purpose of trying to maintain homeostasis. The hypothalamus, this is a really tiny brain region with very big responsibilities. This one actually regulates the body functions and emotions. It connects really closely with the nervous system and the endocrine system, so it kind of plays a uniting role, so to speak. It produces hormones that tell the pituitary gland what to do. So the hypothalamus produces hormones that tells the pituitary what to do. So that's the target organ or the target area that it hits. It is closely linked to the pituitary via some blood vessels. So close proximity, directly tied to blood vessels. So when it secretes hormones out of the hypothalamus, it can directly impact the pituitary relatively quickly. Think of the pituitary gland as a really important little boss in your body. It's a really small gland located in the base of the brain. It's very, very small. The pituitary gland actually sends out signals in the form of these chemical hormones that tell other glands in your body what to do. So it's kind of the boss or the coach, kind of telling everybody what to do. It's sending out assignments and telling them their jobs. These other glands then are part of the endocrine system, which they in turn are all about hormones as well. So we have a gland that submits hormones to tell other glands what hormones to secrete. So these pituitary hormones are called tropic hormones, and that's just a fancy word to emphasize that these hormones control other endocrine glands. Easy for me to say. They don't directly do the main jobs themselves. They simply tell the other glands what to do or when to do it. Beyond just controlling the glands, the pituitary also releases hormones that directly affect other body functions, such as the antidiuretic hormone that helps your body control how much water it keeps, or, for instance, oxytocin, which is a hormone involved in things like social bonding or childbirth. So the pituitary gland is like a control center, but it uses hormones to manage the other glands that it is in control over, and to directly regulate some of the key processes that go on in our bodies. The thyroid gland also releases hormones, but these hormones regulate metabolism. Its activity is triggered by stimulation from the anterior pituitary gland. The thyroid secretes thyroxine, which is when it secretes this thyroxine hormone when the metabolic rate drops. Thyroxine is the main metabolic hormone, and it stimulates energy productions in the cells, so it kind of kicks things into gear. But it needs iodine in order to be produced. Low thioxine will result in a stunted physical and mental growth in developing children. And of course, this whole system here is actually regulated by that negative feedback loop, or a negative feedback system. The thyroid gland also releases calcitonin, which helps to regulate blood calcium levels. This encourages bone cells to absorb excess calcium, and it promotes the kidneys to filter and excrete extra calcium that is not needed. The parathyroid glands help to regulate calcium levels in the blood. By releasing the parathyroid hormone when calcium levels get low, this is in opposition to calcitonin. This stimulates the breakdown of calcium from the bones. And this also reduces the amount of calcium that is actually excreted in urine. So this parathyroid hormone, unlike the calcitonin, parathyroid hormone is actually going to make us hold on to or liberate calcium, whereas the calcitonin hormone is going to make us kind of either store it or get rid of it. The thymus gland supports the immune system by helping it recognize and destroy foreign invaders. So the thymus kind of plays a role in the immune system. Of course, the pancreas, we're all probably pretty familiar with the pancreas, especially since we talked about it in the digestive emergencies chapter. But it functions as both endocrine and exocrine gland. And remember, the exocrine portion releases digestive enzymes into the duodenum through the pancreatic duct, and these aid in the digestion, breaking down of fats and different things such as that during the digestive process. And that's the exocrine part of the pancreas. That's the job, the exocrine side of what the pancreas does. The endocrine portion of the pancreas is known as the islets of Langerhans, and they consist of 3 types of cells. And most people mistakenly think that the endocrine side of the pancreas is equal to the size of the exocrine size. It is a very low percentage. It is those islets of Langerhans only make up about 1% to 2% of the overall cell mass of the pancreas. So the 3 types of cells that make up the islets of Langerhans are alpha cells, and these cells secrete glucagon, and they're designed to raise blood sugar. There's also beta cells, which produce insulin to lower blood sugar levels, and then there's delta cells, which release this substance called somatostatin, and this helps to regulate the balance between glucagon and insulin. So it's all about glucagon and insulin. The pancreas will secrete glucagon if the blood glucose drops, and effectively telling the liver to convert glycogen into glucose and then release it. So when the blood glucose drops, the pancreas will say, we'll secrete glucagon in order to tell the liver to begin breaking down and converting glycogen into glucose so that the body is able to maintain energy levels. It'll also secrete insulin when the blood glucose rises. Insulin moves glucose into the cells and promotes the liver to store glucose as glycogen for future needs. Insulin is the only hormone that is capable of lowering blood sugar. The adrenal glands sit on top of each kidney. There's one on either side. They're made up of 2 main parts. There's the adrenal cortex, which is the outer layer, and the adrenal medulla, or the inner layer. The adrenal cortex releases a substance called aldosterone when the blood pressure drops or the blood volume is low, and maybe even when sodium levels fall or potassium levels rise. Aldosterone signals the kidneys to save sodium and get rid of potassium, helping to balance electrolytes and keep the blood pressure in order. The adrenal medulla is responsible for the fight or flight, or maybe the symptoms that we see on the fight or flight side of things. During the fight or flight response, the hypothalamus triggers the adrenal medulla to release norepinephrine and epinephrine. Of course, norepinephrine is going to raise the blood pressure by causing the vessels to tighten and also relax the airways. Epinephrine acts in the sympathetic nervous system, helping the body respond to stress by increasing energy via glucose and improving blood flow to key organs like the brain, heart, muscles, lungs, so that the body can respond. Now, the main job of the gonads is to drive sexual maturation and to support the reproductive functions. In men, the testes produce hormones called androgens, which control and change the things that happen during puberty. The most important androgen of these is testosterone, but realize there are some others. In women, the ovaries produce two primary hormones, estrogen and progesterone. Estrogen signals the anterior pituitary to release luteinizing hormones during the follicle development. Estrogen also regulates the menstrual cycle and supports the development of secondary sex characteristics at puberty. Progesterone, on the other hand, prepares the uterine lining for implantation of a fertilized egg. Both of these hormones are essential in regulating the menstrual cycle and maintaining overall reproductive health. When we're assessing patients that may have an endocrine-related emergency, always consider that these emergencies can impact multiple organ systems, so it's important not to underestimate the seriousness of these emergencies. Start by addressing any hazards, of course, following those standard precautions. Look around for maybe some medications that might provide some helpful clues, on bedside tables, medicine cabinets, refrigerators. Insulin is oftentimes kept in the refrigerator. And of course, make sure to bring any of those medication bottles with you to the hospital, because it's going to contain valuable information that the hospital may need in determining what's going on. Of course, follow the usual ABC approach. Quickly identify and manage any life threats that may be present, and then begin to form that general impression. Look for those signs and symptoms, because the signs and symptoms may depend on which hormone production or secretion is affected. If the patient is alert or has their is the patient alert or has their mental status changed? This is really important to know. If the patient is unresponsive, it could be due to an endocrine crisis such as hypoglycemia, hyperglycemia. It could be a myxedema coma. Look for diaphoresis, because this can indicate severe distress that is common in conditions like thyrotoxicosis, often accompanied by pulmonary edema. So that diaphoresis is a big indicator that larger parts of the system may be involved, and larger different hormonal releases may be going on as well in response to that. There are some signs and symptoms that are indicative to very specific conditions. For instance, with Cushing's syndrome, we might look for that buffalo hump or moon face and maybe even acne. And we'll talk about Cushing's syndrome a little bit later. Pancreatitis, you might see some mottled skin. There may be the presence of an enlarged or abnormal body parts that might indicate edema in conditions like syndrome of inappropriate antidiuretic hormone, or even maybe anascarcia with myxedemic coma. Recent weight changes could be clues as well. Being underweight or overweight can point to an endocrine issue such as hypothyroidism, hyperthyroidism, or even diabetes. Of course, with Graves' disease, you might see the protruding eyeballs. So we're going to talk about a few of these a little bit more in detail later, but noticing these things should start to give you some indication of what might be going on, and it's going to kind of help guide your next steps. Regardless of everything else, of course, we always want to make sure that the airway is open and clear, that they're breathing and everything's working fine. There are instances that Oxygen, supplemental oxygen plays a critical role with some endocrine emergencies, but not necessarily with others. So we want to just make sure and we monitor their oxygen levels and that they're at a level that's appropriate for them. Check for any possible airway obstructions that may be present, of course, and then assess the patient's quality of breathing, the rate, rhythm, effort. All of those kinds of things are all important when we're assessing a potential endocrine emergency. Check skin color, moisture, and temperature. Get a good set of baseline vital signs or baseline blood pressure. Remember that pale, cool, moist skin can indicate shock or even possible hypoglycemia. Hot, dry skin could suggest that maybe there's a fever or maybe even hyperglycemia. Of course, IV fluids may be needed depending on the situation that's going on. Most endocrine emergency patients should be taken to a facility that specializes in endocrine conditions. And that facility may not be always readily apparent, so you may need to contact medical control for a little bit better direction on exactly where you should take them. Sometimes the family members are helpful with this and they can let you know where the patient typically gets treated. However, if the patient's condition is unstable, it's important that we transport them quickly to the nearest facility. History taking is going to prove to be especially important in diabetic emergencies. Focus on the chief complaint and the history of the present illness. Pay attention to the patient's signs, symptoms, and any key details you might be missing. Look for the hidden. If the patient is unresponsive, check their blood glucose levels and address any abnormalities that you find. Use the mnemonic sample to gather the information that you need. In patients with undiagnosed or poorly managed diabetes, look for signs like excessive hunger, frequent urination, excessive thirst, because those can be indications of where the disease process of diabetes is at. Be aware that hyperthyroidism and thyrotoxis may be present with dysrhythmias like tachycardia, PVCs, PACs, and atrial disturbances. Before administering medications, always confirm allergies and be sure to document current medications and whether or not they've been compliant with their medications. For female patients of childbearing age, ask about the date of their last menstrual cycle so that we can maybe start to rule some things out. Secondary assessment, we should start by simply observing the patient. Note their general appearance and the position of the patient is in when we found them. Look for as many unusual findings as possible. A focused exam with these patients isn't usually needed unless there is some suspicion of trauma. And in trauma cases, a full body exam is much more appropriate. Always address those severe life threats first when you come across them. Pay attention to the finer details, like the skin color, because they can help guide your treatment. As mentioned earlier, cold and clammy skin may indicate shock or hypoglycemia. Cold, dry skin could suggest sedative overdose or alcohol intoxication. And hot, dry skin is often seen in hyperglycemia or patients with a fever or possibly even a heat stroke. For the comatose patient, thoroughly assess the patient's level of consciousness as best you can and work to identify the cause of the coma. Watch for a combination of hypertension and bradycardia, which can indicate increased intracranial pressure. Be aware of abnormal breathing patterns such as Cheyne-Stokes, often suggested of a non-neurologic cause of coma. Kussmaul respirations are typically associated with diabetic ketoacidosis. And there are some more concerning abdominal patterns, which would be central neurologic ventilations or huffing and puffing with minimal airflow. Pay attention to respiratory related movements such as sneezing and yawning, which do require an intact brainstem for those to happen, so it can give you kind of an idea of functional levels. Hiccuping and coughing, however, could be an indication of brainstem damage. When we're reassessing these patients, of course, we need to continually reassess them so that we can spot any changes. If there's an absent gag reflex, remember the patient can't protect their airway from aspiration, so it's up to us to make sure that we protect that for them. For our diabetic patients, make sure we get our blood specimens early if that's required by your protocol. Don't forget to address the patient's emotional needs along the way. And of course, always monitor the cardiac rhythm in a comatose patient. When doing a neurological assessment, be sure to focus on trends across multiple measurements and not just one or two things. If the patient is alert, start an IV with normal saline, or you can use a saline lock. And of course, check that glucose level, the blood glucose level, and treat it if it's below 60 milligrams per deciliter. Administer D50 according to your protocols. Some systems, though, may use glucagon, or they may even use a D10, which is 10% dextrose, instead of D50. Of course, if the patient doesn't show improvement after dextrose administration, you may want to start to suspect that narcotics may be involved and consider administering Narcan. Of course, that's all going to be protocol dependent. Now, when you're transporting these patients, you might want to consider some things. If they're intubated, we need to make sure we transport them supine with the cervical collar in place, which is pretty standard. If the patient is not intubated, transport them in a stable side position. We're going to lay them on their side. If there are signs of increasing intracranial pressure, elevate the head 30 to 45 degrees and keep it midline. This will help reduce the increasing intracranial pressure from building up. Of course, continuously suction the mouth and pharynx to keep them clear from secretions like vomit or blood if that's an issue as well. So, glucose metabolic derangements. When we're dealing with glucose metabolic derangements, remember that endocrine disorders occur when a gland either produces too much or too little of some particular hormone. So if we have a hypersecretion, that typically leads to overactivity of the organ or gland that it regulates. And if those secretions are inefficient, the result is underactivity of an organ or gland that it controls. Glucose metabolic disorders are caused by problems with the pancreas, which affect the body's ability to process glucose. So we're specifically talking about glucose-related issues. The most serious endocrine emergencies can lead to a compromise of the ABCs, fluid imbalances, and of course, deteriorating mental status along with abnormal vital signs and blood glucose levels. So the most serious of the things that we deal with can have some very significant consequences. Now, diabetes is one of those that we're going to talk about that kind of fall in that category. And this is a group of metabolic disorders that includes several conditions with different causes. So we have diabetes mellitus, gestational diabetes, we have hypoglycemia, hyperglycemia, diabetic ketoacidosis, and then this long-winded one, the hyperosmolar hyperglycemic non-ketonic syndrome. From here on out, I'm going to call it HHNS. I'm not going to try to say that again. So, and we're going to talk about each one of those a little bit more in detail. Some of them we won't get too far off into the weeds on, but we will kind of mention them. So simply put, diabetes is a metabolic disorder where the body can't properly metabolize simple carbohydrates. Some key characteristics of diabetes is they typically have an increased hunger because the glucose can't enter the cells, and they have an intense thirst because the dehydration that's caused from the increased urination of the body trying to get rid of the excess glucose that it can't get to the cells. And then because of that, we'll see an increase in the amount of glucose in that person's urine. Now recall, we think back into your anatomy and physiology class and how the Krebs cycle utilizes glucose along with oxygen as the primary fuel for cellular metabolism and in creating that energy that the cells need to function. So we have to have both of those. Of course, diabetes is when the body lacks the ability to properly metabolize glucose, meaning we can't get the glucose into the cells where it can be utilized by the cells. This happens because the pancreas doesn't produce enough insulin, or the body's cells don't respond to the insulin that's being produced. So one of the two. As a result, blood glucose levels will rise and glucose begins to appear in the urine. As the glucose levels build up, it's excreted out of the body, and then the cells can essentially starve due to a lack of glucose, even though they're surrounded by glucose. Because without the insulin to carry the glucose into the cells, the glucose might as well not exist. Untreated or uncontrolled diabetes can result in some severe life-altering complications. Diabetes is actually the leading cause for kidney failure in the world. High blood glucose levels can cause the kidneys' glomeruli to become sclerotic and lead to necrosis of the papillary tissues. It will also lead to some neuropathy and even renal failure. Over time, high glucose levels can decrease the kidney's function. Adults with diabetes are twice as likely to die from heart disease or have a stroke. Poorly controlled diabetes leads to lipolysis, which raises fat levels in the blood and increases the risk of atherosclerosis and coronary artery disease. The microangiopathy is that damage to those small blood vessels. This can cause restrictions in blood flow to organs, leading to ischemia and even necrosis where the organ tissue begins to die. Chronic heart failure may be related to this as well, which can lead to some cardiac dysrhythmias. Microangiopathy and neuropathy raise the risk levels of silent myocardial infarctions or silent MIs, where the patient may not feel the typical chest pain or tightness associated with a heart attack. Always assume that it's an acute myocardial infarction until proven otherwise. Diabetes also raises the risk factor for CVAs due to the damage that it causes in those small blood vessels and the increasing risk of stroke. Peripheral artery disease is a common issue as well because it impairs the circulation to the lower extremities. Hypertension increases the risk of heart disease, stroke, kidney disease, and even blindness. Diabetes is the leading cause of new blindness cases in adults 18 to 64. High blood glucose damages blood vessels in the eye. Scar tissues can pull the retina away from the eye, causing retinal detachment. And then, of course, cataracts may form as fructose and sorbitol build up in the lens of the eye. So there's nothing good about diabetes, nothing good at all. All of those things that isolated, the risk of CVAs or the risk of heart attacks and the buildup of plaques and atherosclerosis and all those things in and of themselves, absent diabetes, are bad enough, but you add diabetes in there and the risk factors grow up exponentially. Nerve damage can also be caused by diabetes, and it leads to the loss of sensation and function of that particular part of the body. This often affects the peripheral nerves, causing a reduced sensation in the extremities, often defined as paresthesia or dysthesia, and this can dull the pain perception, allowing foot ulcers to go unnoticed or allow them to get infected, which may develop gangrene in the surrounding tissues due to poor circulation. And infections become much more common and can spread to the bone, potentially requiring amputation in these patients. Many diabetes-related conditions can be delayed or prevented with lifestyle changes and proper management. Blood glucose control is harder during stress and physical activity, though. There are some complications of diabetes that are more severe in those who need insulin. If left untreated, diabetes can lead to organ dysfunction, tissue wasting, and of course death. The severity of complications actually depends on the average blood glucose levels and the age at which the diabetes began. Of course, as of right now, there is no cure for diabetes. So the first of these types of diabetes we're going to talk about, ironically enough, is type 1 diabetes, also known as insulin-dependent diabetes or juvenile onset diabetes. This usually first affects children when it usually shows up. It's commonly associated with as a childhood disease, but it sticks with them all the way through adulthood. While genetics does play a role, there are some environmental factors that may contribute as well. What happens is the body mistakenly creates autoantibodies that attack and kill its own tissues. The pancreatic beta cells lose their ability to produce insulin, making it impossible to regulate glucose because they've been attacked and destroyed by these autoantibodies. Because of this, insulin must be given by injection or through a pump. Latent autoimmune diabetes in adults is a form of type 1 diabetes that affects adults typically over the age of 30. With these patients, with all type 1 diabetes patients, strict dietary control is necessary. Increased activity or alcohol can actually lead to low blood glucose levels, dangerously low. When assessing a type 1 diabetic patient, check if the patient has been compliant with their diabetes management. That's going to be a big indicator of what you may have to expect. If the patient has altered mental status, suspect a low blood glucose level, but keep an eye out for other chronic conditions such as renal failure, heart failure, coronary artery disease, hypertension, vision and hearing impairments, because these all could go hand in hand with diabetes, especially those patients that have been less compliant or that have had a tougher go of it, have had more issues. On a side note, just because a patient has those things, renal failure, heart failure, coronary artery disease, vision and hearing impairment kind of things, doesn't necessarily mean that they've been non-compliant and they haven't taken care of themselves. Some diabetics are really, really hard to manage. Some of those cases are really, really difficult and they struggle greatly. So we should closely inspect for sores or infections that may be signs of a more serious developing issue. It may seem like those sores or infections on the extremities, maybe the heels of the feet or those kinds of things, seem less important, but they could play into the bigger picture of why you're there taking care of them today. Ask about symptoms like vision changes, headaches, dizziness, bleeding, sores in the mouth, and even recent changes to bowel or eating habits, because those can help narrow things down. Realize that type 1 diabetes may very well require insulin. If their blood sugar is too high, they're going to require insulin. Of course, the insulin must be given through injection or through a pump. It can't be taken orally because the process of digestion renders insulin inactive. Some patients use pumps as an alternative to multiple daily injections, and the pump usually consists of some sort of infusion set of tubing, an insulin reservoir, and the pump itself. The pump is not very big, typically about the size of a deck of cards or a very small pager, if you guys remember what a pager is. It weighs about 3 ounces. It can be worn on a belt or put in a pocket. And then the insulin is delivered through a catheter that's sticking through the skin. The pump can continuously deliver a basal amount of insulin, or it can be set to deliver a bolus at specific times, like meal times or when glucose is high. There are several types of insulin. There's rapid acting, short acting, intermediate acting, and long acting insulin. So there's different types and they come from different sources. They differ in their onset, duration, and peak time, so the patient will be much more familiar with this. And this is why insulin is not typically given in the field, because giving insulin requires special training and knowledge and education due to the fact that even the smallest error in insulin administration can be quickly fatal. Type 2 diabetes is actually the most common. It affects about 99 to 95% of all diabetics in the US, and roughly about 8.5% of the total global population. The blood glucose levels are high in type 2 diabetics because their body either can't produce enough insulin or it can't use the insulin that it produces, known as insulin resistance. In some cases, the liver produces too much glucose, especially when glucagon levels stay elevated. This also contributes to a higher blood sugar. Metformin, a commonly prescribed medication, helps to reduce the amount of glucose that's released from the liver. Development of type 2 diabetes is strongly linked to obesity, physical inactivity, of course, genetics that you can't get away from, and of course, these same factors can also lead to metabolic syndrome. Common symptoms of type 2 diabetes will include nausea, vomiting, frequent urination, and consistent thirst, very similar to what we see in type 1s, unexplained weight loss, blurred vision, frequent infections and slow healing, mood changes, shakiness, those kinds of things. Symptoms usually develop gradually and often show up in middle age. Some people, though it's a small percentage, may actually have no symptoms at all for a very long time. Management's going to typically start with lifestyle changes that include weight loss, regular exercise, and a healthy diet. Meals should be spaced out across the day and timed with medications or with their insulin as needed. Oral medications are often used for type 2 diabetics, either by themselves or in combination with other medications or even insulin, depending on the patient's needs and where they're at. There has been an advent of new, the GLP-1 medications that probably everybody's heard about. This approach is really helpful in treating type 2 diabetics, but generally speaking, the approach has not really changed. But the new medication, this new GLP-1 type medication, has proven to show some benefits in many ways for patients that are type 2 diabetics. Prediabetes, this is actually linked to the same risk factors as type 2 diabetes. It means blood glucose or A1C levels are higher than normal, but not so high that it would be considered diabetes. The A1C test shows the average glucose levels over the past 3 months. About 1 in 3 US adults, roughly 88 million, have prediabetes, and most don't know it. Without lifestyle changes, many will actually go on to develop type 2 diabetes within 5 years. Risk factors for prediabetes include things like being overweight, over 45, having a parent or sibling with type 2 diabetes, if they participate in physical activities less than 3 times a week, if they had a history of gestational diabetes during pregnancy, or if they have polycystic ovary syndrome. Prevention makes the biggest impact. Just making 2 lifestyle changes can cut the risk of developing type 2 diabetes down by almost 60%. Lose 5 to 7% of your body weight and get at least 150 minutes of physical activity per week, and you can bend that curve of type 2 diabetes likelihood down significantly. Now, gestational diabetes is a little different. It's basically a form of glucose intolerance that shows up during pregnancy. So obviously women are going to be the ones that are at most risk for this, but there's some groups within that category that are even at higher risk, such as African Americans, Hispanic Latinos, Native Americans, obese patients as well, and those that have a family history of diabetes are at the highest risk of developing gestational diabetes. And then having gestational diabetes actually increases the mother's risk of developing type 2 diabetes later in life by about 40 to 60%. In most cases, though, the issue kind of goes away. The diabetes issue goes away after delivery. This is usually diagnosed around the 28th week and peaks by about the 3rd trimester. This is when the placental hormones may interfere with how the body uses insulin. Unlike other forms of diabetes, this particular form does not cause or is not related to birth defects. So the way that they diagnose gestational diabetes is they do an oral glucose tolerance test. It is the standard method for diagnosing gestational diabetes. It's usually done during pregnancy and up to the 12 weeks and up to 12 weeks after delivery, not before pregnancy, but during and up to 12 weeks after. Hemoglobin, the hemoglobin A1C may be used at the first prenatal visit to check for pre-existing diabetes and pre-diabetes conditions that might be an indication of a predisposition to gestational diabetes. The primary management goal, of course, is going to be to stabilize blood glucose levels as early as possible. This typically involves diet changes, some exercise, and that routine glucose monitoring. Insulin injections may actually be needed for blood sugars that can't be controlled with lifestyle and exercise alone. Okay, so that is the end of the first half of endocrine emergencies, and we will be back in just a little bit. I say we, I, me. I will be back in just a little bit to cover part 2.